Thank you very much for the very kind introduction. And yes, indeed, my last time here was in 1995. And there was something about coming down Morrison Street and walking into the building that made me want to check that my socks were pulled up and that my shirt was tucked in. And I'm still feeling a little bit sort of tachycardic in that, but hopefully I'm okay. And hopefully no one gives me Friday detention. Indeed, I'm a blood doctor. That's what I do, and so I see patients with blood diseases every week. There are many types of blood disease, but the blood disease that is most common around the world is anemia. And anemia means that the amount of hemoglobin, the amount of oxygen carrying capacity in your blood is reduced. And so this is a picture on the left. If you look under the eyes, the conjunctiva of a little kid that I saw when I worked in East Timor, and look how pale those eyes are, the conjunctiva are. Whereas if you look at a healthy one at the top, you can see what a healthy conjunctiva would look like. You can go home and check in the mirror tonight. And so hemoglobin is a deficit in how many circulating red blood cells you have. These red blood cells carry oxygen all over your body. And there are a lot of anemic people here in Australia, but I really got interested in this problem because a couple of years after I finished medical school, this is going to be before many of you were born, I went off to East Timor, which is north of Australia, and had just come through a major change in their government and was a very new country. And I went to East Timor because there were very few doctors, and I was barely qualified. I knew a little bit about what I was doing. But during my time in East Timor, I worked as a doctor, and we used to go on these remote village visits. So that would be the ambulance would drive all over the villages and the mountains of East Timor and go to different villages where there was no medical care, and I would look after and meet patients and look after them and help them with care. But I was also interested in blood diseases, and I really wondered, well, how can I intersect these two interests? How can I find a role and an interest where I could bring together my really deep interest in looking after people who live in low-income settings with my interest in blood disorders. And then I realised that, well, a blood disorder is perhaps the most common condition in the world. Anemia affects, in fact, 3 out of every 5 babies in the world, and about 1 in 3 pregnant women, just for starters. It also affects about 1 in 5 women in total. And anemia can be really debilitating. So just imagine you have a reduced hemoglobin, you have reduced oxygen carrying capacity around your body. What does that mean? It means that when you exert yourself, when you run, I saw a lot of your colleagues running all over the oval. If they were anemic, they'd be short of breath. They wouldn't be able to perform. I saw little kids can't grow and develop the way that they should. Pregnant women are at risk of dying during childbirth if they're anemic. And this condition affects so many people. And so with that in mind, I embarked on a career in trying to understand how to measure, how to prevent, and how to treat anemia for people in low-income countries around the world. And so I became interested in this in around about 2008 when I got back from East Timor, started my training and thought, what am I going to do? How am I going to take this further? And so in around about 2008, I thought, I want to go into the field and I want to do my own study on the problem of anemia. And at that time, there was no data, no knowledge about what were the causes of anemia in young kids in India. India, a country of 1 billion people and the world capital of anemia, a place where about 4 to 5 out of every young kids was anemic, and we didn't actually know why at that time. So with my grand plan in my head, and with my fiancée, she's still stuck with me. We picked up stumps and we moved to rural India. So this is the sort of village that I was working in and living in 2008. So you can see not a lot there, and a population in a rural setting. I was spending time sleeping on the floors, interacting with local clinicians, but and interacting with people in the village. But the truth is, I had no idea what I was doing. I didn't have any funding. I didn't have a team. I didn't have a plan. And the truth is, I had no idea what I was doing. So yes, great idea, but no knowledge or skills. So luckily, I had support from colleagues here in Melbourne who helped mentor me. But what I really needed to do was build a team. And so through contacts from asking a lot of people and a lot of terror for the idea that I was living in a long way from home with no clues of what I was actually doing, I eventually built a small team of local women, including some who were medically and clinically experienced but not doctors. And we built a team and a study that would go around the villages of India with and collect blood samples from young kids. And so can you imagine, I don't know how many of you have younger siblings, but if you try to take blood from a 2-year-old, it's not a pretty situation, especially in a village. So we trained our team how to engage with the local community, how to develop the plan in partnership with them, and then we actually collected blood for the first time and with the ability to collect really detailed types of blood tests to see what was causing anemia out in these villages with this fantastic team that we built up to help me. We had to analyse those samples and process them in some pretty rough scenarios. So you can see here the types of places we were collecting blood. Probably looks a little bit different to the nurses' station here at the school. And that was our lab. So no electricity at night, or we'd have to run a generator in order to be able to spin the samples, to purify the samples, and of course to look down samples down the microscope. So we were working in those conditions to collect our blood samples. And so after doing that in the field, working for months and months, getting sick quite often, we eventually collected all this data, and it turned out to be the first data that could tell us the determinants of anemia in young kids in rural India. And the way we eventually were able to publish this in an important peer-reviewed journal, and you can see here, this I was checking when I was preparing this talk, this paper has been referenced by other papers over 400 times, meaning that this really was the first such study that has really built a bedrock for how people can develop strategies to improve anemia in rural India. Based on that work, I had the opportunity to travel to Geneva and work at the World Health Organization. Now this, you would know a lot about WHO. This is a place where they make global policy around a whole number of different issues, including nutrition and how we solve anemia. So I was there. At that time, I was actually already a senior consultant doctor. I was thinking I was very important. So I showed up at WHO. They put me at that desk, which had a good view, and they said, your job is to transcribe these data sets from hard copy photocopies into the electronic database. So literally, there I was, a specialist doctor with a PhD, and my job was to type. But I did it, and I didn't complain too much. And now, actually, a lot of the data that you'll find in the global database on the prevalence of anemia right around the world is actually stuff I hand-entered from these hard-copied data. But the lesson there was, whilst I would say I went home and complained to my wife every night, what did come of it was that we were able to go on to use that evidence to find gaps in knowledge around the world. And eventually, all of that work became the global guideline for how anemia should be treated around the world. And this is still the guideline that's used by WHO to instruct countries right around the world on how they should inform anemia policy. Now, based on all of that work, I realized there was this gap. There was a piece of knowledge missing that I could not sleep at night. I was so upset by. And for those of you who enjoy science or getting your minds that way, one day you will be struck by a hypothesis. And when that day comes, you won't be able to sleep. You will be obsessed by your hypothesis. And I was consumed by the idea that there was a certain piece of knowledge about the way we treat anemia in countries, in low-income countries, that we didn't know how to do. And so I went around and upset everybody I spoke to. My previous PhD supervisor agreed to help me, and we planned a study, an enormous study in rural Bangladesh, where we would test this hypothesis using a large clinical trial. And I planned it, and I thought, this is the best thing since sliced bread. This is amazing. We have to do this. So I wrote my grant, sent it to the Australian government. It's called the NHMRC, and they sent me this letter, which was, thanks, but no thanks. We aren't funding you, stiff bickies. So that is the sort of letter that was my first rejection letter. I've had many of these, and I'll show them to you. since then. And this is what it looks like when you don't get your grant. And in Australia, a bit like Year 12, you only get to do it once a year. So when you don't get your grant, you have to wait a year. And so the next year, we got it. It was amazing. And this was a life-changing moment. And so with this grant, we were able to go on and now run this enormous randomized trial where we visited women and families all over rural Bangladesh, and we were collecting data, and we studied 3,300 babies, and through that I had a team of more than 100 people. So from that small group of just 5 or 6 women that I showed you before, we now had a team of over 100 staff helping us with these studies. And this study actually got published in the world's top journal, the New England Journal, and provided evidence for WHO on what should happen next. And actually, earlier this year, we were awarded by the NHMRC to be one of the top grants that actually funded over the last few years. So proves that so I'm just showing that there. I shouldn't say "told you so," but I will if anyone from NHMRC was listening. And the WHO, after watching me enter data for a few months, actually made our lab their WHO collaborating centre for anaemia. So we now partner with WHO in how they drive anaemia. And this is actually the piece of work we did here, which actually, so if you go to the doctor now and I hope they don't have to do this to you, and they measure your blood and they look to see whether you're anemic, it's the evidence that we built from our group that actually will do that for the whole world, will determine how they make that diagnosis. And based on that, I don't know if you recognise the character on the top right there. I got invited to meet with Bill Gates, and unfortunately it was during the pandemic, so I couldn't go to Seattle, but I got invited to meet with Bill Gates and, just like everyone, have a Zoom call with him, or actually no, Microsoft Teams, and to provide him with some education on anaemia and teach him all about it. And on the basis of that, he was able to fund us to do some further studies on anaemia in both sub-Saharan Africa, in Malawi, and we've done 2 studies there, and we're also working in Bangladesh. But it's not all good news, because when you push yourself, things go wrong. And so this is just some grants. These are some letters I've received in the last few days. That one's from July 25th, and this one was actually just 2 weeks ago, where some more thanks but no thanks. So some more ideas, more studies that we think the world would really benefit on anaemia, but it doesn't always work out. And we get these grants, and of course to write a grant, it takes hundreds to thousands of hours of work to prepare a proposal, and then you get that nice email back in response. Plenty more where those came from. I have an entire laptop full of these emails. I thought the talk would go for 25 minutes if I showed you all my rejections. But just to say that you have your bad days and you have your good days. So tomorrow next week we'll be launching this commission, which is really bringing together the world's experts on anaemia to understand what the next types of research are needed to take things forwards. So for me, what I've found is that it's really been ups and downs, building on what's gone wrong and trying to really strengthen when things go right. So I guess just to wrap up, aligned to the theme of what we're talking about today, for me, I've had no shortage of rejections, and I think it always hurts. It never stops. So really just to take that moment to feel the agony, and then to feel that disappointment. And then to reframe and figure out, well, what can I do better? How can I reposition? And then to go again, to act again, to reload and have another try. And with that, I will pause there. That's a mum and a child from our study in Bangladesh, where we're continuing to work and to hopefully have an impact. Thank you very much.